welcome you to the Soul Repair Center's January webinar, Integrative Mental Health, How Integrating Spiritual Care into Mental Health Care has helped the VA better meet veterans' needs. Our program features the leadership of 4 skilled educators who together support the VA chaplaincy training program, Integrated Mental Health, located at Vanderbilt University Medical School and also related to the Divinity School. My name is Nancy Ramsay. I'm privileged to serve as the director of the Soul Repair Center here at Brite Divinity School in Fort Worth, Texas. The center's website also offers extensive archival resources on moral injury. These free monthly webinars, September through May, inform military and VA chaplains, as well as faculty, religious leaders, and chaplains in various settings who serve retired and active duty military and chaplains in their families. The webinars are co-sponsored by the Shea Center on Moral Injury of the VOA Network. The Shea Center is directed by Dr. Rita Nakashima-Brock, who founded the Soul Repair Center at Brite. For the past 15 years, the Department of Veterans Affairs has championed more intentional integration of spiritual and psychosocial care services through integrative mental health, formerly mental health chaplaincy. This program office has sought to meet the dynamically interrelated biopsychosocial spiritual needs of veterans via numerous research, educational, quality improvement, and community engagement efforts. Today, our presenters will describe efforts in each of these domains and illustrate the importance and interconnectedness of activities in each. They will share an overview of findings from research with veterans, mental health providers, and community clergy. They will also describe their training program, Mental Health Integration for Chaplaincy Services, and note how it provides the foundations for a Doctor of Ministry and Integrative Chaplaincy through Vanderbilt Divinity School. They will also illustrate how chaplaincy mental health integration can effectively address moral injury, an issue at the intersection of psychological and spiritual suffering. Today's webinar features the faculty of the Mental Health and Chaplaincy program. Keith Meador, MD, THM, and MPH, is the Ann Geddes Stallman Professor of Medical Ethics and Professor of Psychiatry and Behavioral Sciences at Vanderbilt University Medical Center and Professor of Ethics and Society at Vanderbilt Divinity School. Dr. Meador is Director of Integrative Mental Health, a national initiative to foster integration of chaplaincy services into mental health care within the Department of Veteran Affairs. Dr. Meador joined the faculty at the Vanderbilt Medical School in 2010 in the Psychiatry Department. Since 2012, he has served as the Director of the Center for Biomedical Ethics and Society at Vanderbilt in July. He began his work at Vanderbilt in July of 2010 as Vice Chair for Psychiatry, prior to becoming Director of the Center. He's board certified as a psychiatrist with training in theology and public health. Dr. Meador is a graduate of Vanderbilt University and received his medical degree from the University of Louisville. He completed his residency in psychiatry and fellowship in aging and human development at Duke University, and he holds a THM from Duke Divinity School. He received his MPH in epidemiology from the University of North Carolina at Chapel Hill. Dr. Meador's publications build on his clinical experience, research, and teaching in mental and public health and ethics, with particular attention to intersections of religion and health and social cultural determinants and implications for illness, health, and human well-being. He is the co-author of Heal Thyself, Spirituality, Medicine, and the Distortion of Christianity. Jason Nieuwsma, PhD, is a clinical psychologist who serves as the Associate Director for the VA Integrative Mental Health and holds faculty positions at Duke University Medical School and Vanderbilt Divinity School. His work focuses on increasing the availability and cultural relevance of evidence-based psychosocial approaches across various contexts, with areas of expertise in health, psychology, cross-cultural psychology, dissemination and implementation science, and spirituality and health. In recent years, Dr. Nieuwsma has helped to lead multiple national-level projects aimed at more effectively integrating chaplaincy and mental health care services. Dr. Nieuwsma has authored numerous journal articles and book chapters, serves as Senior Associate Editor for the Journal of Healthcare Chaplaincy, and has co-authored the book Acts for Clergy and Pastoral Counselors and Addressing Moral Injury in Clinical Practice. Jennifer Wortmann, PhD, is a licensed psychologist with VA Integrative Mental Health. She serves as instructor and consultant to chaplains in the Mental Health Integration for Chaplain Services intensive training program, which forms the core of the first 3 semesters of the Doctor of Ministry degree in intensive chaplaincy, offered by Vanderbilt Divinity School. Dr. Wortmann is engaged in a variety of research, educational, and clinical efforts related to mental health and chaplaincy integration. She completed her undergraduate education at North Park University, graduate work at the University of Connecticut, clinical internship at the VA Connecticut Healthcare System, and postdoctoral training in PTSD and moral injury at the VA Boston Healthcare System. Her work has focused on the intersection of religion and spirituality with PTSD, moral injury, and meaning-making in the context of trauma, bereavement, serious illness, and young adult life transitions. Dr. Wortmann has added additional expertise in measure development and psychometric evaluation. Melissa Smigelsky, PhD, is a member of the board of the Soul Repair Center, a licensed psychologist with VA Integrative Mental Health. Dr. Smigelsky's work with IMH focuses on equipping VA chaplains and mental health clinicians to provide moral injury care that integrates evidence-based psychosocial principles with spiritual care practices. Dr. Smigelsky facilitates an expanding network of chaplain mental health teams and individual providers that focus on the development, refinement, implementation, and dissemination of promising practices for moral injury. Dr. Smigelsky has collaborated with VA chaplains and mental health clinicians to develop a group therapy approach to address moral injury and provides moral injury care to veterans within the Durham VA healthcare system. The first hour of this webinar will proceed with each of our panelists presenting, and at approximately 2:45 Eastern Time, the presenters and I will have an opportunity to talk together. At 3 p.m. Eastern, we'll focus on the questions and observations you share in the chat. We will conclude at 3:30 Eastern Time. A recording of the webinar will be available at the Soul Repair Center website and the VOA's YouTube channel within about 6 days, and then be available for viewing. We are assisted in this webinar by Sam McAllister, Production Manager for the VOA, and Dr. Kyle Fauntleroy, Retired Captain in the U.S. Navy Chaplaincy and a Development Officer at Brite, who will monitor the chat. Now, we turn to our presenters for this first portion of the webinar.
Thank you, Nancy. Do we have our first slide, Sam? Thank you so much, Nancy. We appreciate your invitation and opportunity to be part of this webinar series and this distinguished history that's evolved under your leadership as well as Rita Brock's. We at Integrative Mental Health do look forward to sharing some time with you, and we'll try to be efficient, and I'll get started quite quickly. If you go on to the next slide, Sam. The program initiated in 2008, as Nancy has alluded to, originally called Mental Health and Chaplaincy, which I think specifically notes where we have engaged the most in our commitments to integrating emotional, social, psychological, and spiritual care interconnected with between spirituality and health sort of domains. We work with chaplains. We have other connections throughout the system, but our primary commitment from the beginning has been working with chaplains within both the VA and DoD for a number of years. We do see that as being the most opportune way to offer integrated, optimal care for veterans and service members as well as their families through the commitments that are embodied within our work of equipping for collaboration and building communities of care. I think you'll see this notion of communities of care and commitment to collaboration throughout the thread that we'll be presenting with you today. Next slide, please. This slide conveys, hopefully, the big picture for us of who we are, for those of you who might not know that before. A number of you on the webinar with us today may be aware of this, but we have been supported for throughout the time since 2008 out of the Office of Mental Health, and then which was progressed on to being called the Office of Mental Health and Suicide Prevention in DC. We are housed within the Vision 6 MIRAC and have close colleagues there that have been with us since the origination of our program as well. We're delighted to have the opportunity as a team that you're meeting today, along with a few other folks that have worked with us through the years as chaplain coaches and others that we really value, to work with the partners that are listed down at the bottom of this slide. We consider National Chaplain Service an integral part of our work. They've been very complementary partners with us in our work throughout the time since 2008, back to the era some of you may know of Keith Etheridge and others, and of course currently under the leadership of Kimberly Willis, who we see as a vital partner in this work. VA HSR&D has been a longstanding colleague as well through George Jackson and others in HSR&D and at the Durham VA, as well as other sites. Innovation Ecosystem and the Office of Rural Health have both been large programs within the VA that have been supportive and good partners through the years, as well as other medical centers across the country. And as we've alluded to, our work with Vanderbilt and other university affiliates. We do consider DoD to be an integral part of our work, growing out of the original work we did with the IMHS initiative back in around 2009, where we really have had an integral partnership with DoD colleagues from the beginning in building our training programs, as well as engaging in some of our research and improvement in quality care efforts. We are very grateful to all of these partners and see it as an integral part of our successes through the years, and are delighted to highlight them as we move forward through the conversation, keeping in mind how important those relationships have been for us. Jason, at this point, will go a little more in depth into some of the domains of our work. So appreciate that, Jason.
Thanks, Keith. And you can go to the next slide. Yeah, so thank you, Keith. And thank you again to Nancy for the invitation, as well as to Rita and Kyle and Sam for your support in different ways of this series. So with this slide here, you can see kind of an overarching big picture of some of the key domains of engagement for our integrative mental health program. We'll be talking about three of these. Each one of us, I'll be talking about community engagement, and then Jen, some about training and education, specifically our Doctor of Ministry program that we do now in partnership with Vanderbilt. It started as something that grew out of our integrative mental health program, and over the past few years have been able to offer this DMIN in partnership with Vanderbilt, which is why you can see in my background and in Jen's background, we have the integrative mental health and Vanderbilt slide behind us, because we most commonly use Zoom for work that we do with our VA and DoD chaplains that way. And then Melissa will talk some about work in the area of clinical quality improvement, specifically about work that our program's done with a dynamic diffusion network that has brought together mental health professionals and chaplains to address suicide prevention, and even more intentionally to address moral injury and moral injury group care. And so Melissa will talk about that. In terms of research and scholarship, I noticed that Sam has already shared in the chat that you'll have access to these slides. So we've shared a PDF of this slide deck that we welcome you to look further into any of the links and things that we have in the slide deck. But also at the very end, we have some highlights from recent publications over the past year and a half or so, a number of those on moral injury, and then a full list of lots of different publications out of our program office that we're not going to be going into detail about today. But if you're interested in some of the work that we're talking about, would commend that to you. Next slide. So I'm going to begin by talking about just some of our work in this area of community engagement, and most specifically highlighting some work that was in large part supported by the Bristol Myers Squibb Foundation. Next slide. So we had support from that foundation, as well as some of the other partners that Keith was mentioning within VA, to conduct a project. This was a multi-year project. It began prior to the onset of the pandemic and then kind of continued into that. A project that had two different arms. So you can see the couple different arms at the bottom there. One arm that focused on faith communities, and specifically we were focusing on small groups within these faith communities, and I'll say a bit more about that on the next slide. And then a second arm of this project that was focusing on clergy and mental health care providers in a variety of different local communities across the country, and bringing these providers together to begin to form relationships and partnerships for the delivery of care. Across both of these project arms, we really had one overarching project goal that you can see there at the top, which was focused very much on veterans and persons with mental illness, attempting to create more of a community of welcome and a community of belonging for these individuals. We're out of the VA, so of course we were focused on veterans, but some of these products, and you can access these products at the website that you see there and on the next slide, are freely available, and we had really attempted to make them as something that would, yes, address the needs of veterans, but would also apply more generally to persons with a range of different mental health problems. You can go to the next slide. So again, that first arm was this 4-part series, and so the title of that 4-part series is A Place to Call Home, which consists of 4 different 20-minute videos, and you can see the titles of each one of those 20-minute videos on the screen there. And we had a range of different providers. So we heard from veterans, from their spouses, from pastoral care providers, a rabbi, an imam, a pastor, pastoral counselor. So a range of different individuals who are featured in these videos. And really the intention and the way that we use these as part of the project at more than 20 different faith communities, diverse faith communities across the country, was that a small group, usually of 5 to 12 individuals, would watch this 20-minute video, and then they'd have 45 minutes to an hour, depending how much time they wanted to allocate, to conversation. And there were conversation questions that were specific to each video, but really all of these conversation topics kind of orbited around the topic of creating a community of belonging for veterans and for persons with mental health struggles. And we were encouraged to find, a number of positive outcomes as a result of the evaluation that we did, number of, changes from pre-post. But one of the things that really stuck out to us, and this really came out in many of the qualitative interviews that we did, is folks talking about neat different programs that they'd started up, hiking clubs or a Veterans Day appreciation or something they did at their church, lots of different idiosyncratic things that each community did. But a theme at many places was, as part of these videos, folks often having some introspection where they began to kind of ask themselves the question, do I feel like I can share about my struggle? Or maybe even about my mental health challenges in this community. So there was often a creation of some vulnerability within communities, and from that vulnerability, then these communities beginning to say, "Hey, all of us struggle. This is something that's relevant for all of us." And some of you may be familiar with the Surgeon General report that came out, I think, within the past year or so, that I think they entitled it "Epidemic of Loneliness." But you can just think about all the things that we've been aware of for some time, and that's been highlighted even more recently with that report, by how much things like isolation and loneliness can really have a negative impact on mental health, on physical health. And so how important having a community of belonging is, and even more so if that can be a community of meaning and purpose. And so that was really the intention, and remains the intention. Again, these are available on the website for anyone who may be interested in those. Next slide. The second arm then of this project focused on bringing clergy and mental health professionals together at 12 different sites across the country. We went and we'd hold a day-long event, and you can see the agenda for the day-long event there. And again, we used snippets from videos. Many of the snippets this time, again, we have 2 1-hour videos that are on the website there that are for clergy, and we use snippets from those videos to explore themes having to do with mental health, clergy collaboration, and often some of the skepticism that these disciplines can have of one another. So across these 12 different sites, we brought together around 300 clergy and mental health providers, roughly even distribution of both disciplines. And they got to have these conversations. And, much of the day was really having conversations with one another and starting to build those relationships. Oh, I, could trust you to make a referral or to ask about this person in my congregation, or vice versa. And so again, with those, we saw a number of encouraging developments in terms of the pre-post surveys that we completed. And then next slide. So this slide shows one more product that again is available on our website. This is a separate project, so this was not part of the 2-arm evaluation I was just talking about. But we developed a 3-part video series on upstream suicide prevention. So for those of you familiar with VA and for major efforts in terms of mental health care for veterans, that suicide prevention has been a top priority for many years. And often many of the efforts in that area focus on intervening in crisis situations or near crisis situations, which is extremely important work that absolutely saves lives. With this series, we wanted to think about getting further upstream, so to speak. So not suicide prevention within sort of those crisis moments, but as you can see with many of the topics here, how to address some of those things that, again, would be further upstream or that we might, from a public health perspective, think of in terms of primary prevention. And so these are, each video is an hour long, so human flourishing, stress and resilience, and demographic considerations. And then they each have 3 essentially kind of TED Talks on these different themes. And so we've used these as part of our chaplain training, but we've also used these as part of community engagement, and even some of the faith communities that use the videos I was talking about earlier have used some of these 15-minute videos in much the same way. So want to commend those to you as well. And in terms of talking about education, I will leave my comments here and turn it over to Dr. Jen Wortmann to talk about MIX and our DMIN program.
Thank you, Jason. Sam, you can advance the slide. And a main focus in training and education for integrative mental health, and my primary focus is the MIX training for chaplains that Jason just mentioned. So the next slide, please. So MIX stands for Mental Health Integration for Chaplain Services. And it is worth my reading this whole slide, so I'll do that. MIX is an educational offering spanning 3 academic semesters, and we say here it's available to VA and DoD chaplains, but I want to pause here for an important note. Because of our partnership with Vanderbilt Divinity School, the Doctor of Ministry degree that MIX forms the first 3 semesters of makes MIX accessible outside of VA and DoD. So more on that in a moment, but here I'll continue to describe the foundation of the MIX training itself, because MIX was born out of and has been developed by VA Integrative Mental Health during a decade of collaboration with the partners Keith mentioned before, the Department of Defense, VA National Chaplain Service, and many others. And my colleagues started with an intensive gap analysis of chaplain and mental health practices as part of the VA-DoD Integrated Mental Health Strategy. And that is what provided an extensive empirical basis of input from chaplains in the VA and DoD, from mental health professionals, and from leadership. And all of those empirical findings significantly inform the development of mix. And there's a couple published articles summarizing that work in the Journal of Healthcare Chaplaincy and the Journal of General Internal Medicine. So those resources will be available to you. Next slide, please. This is just a graphic of that process. So the VA DoD Integrated Mental Health Strategy, or IMHS, was funded from about 2010 to 2013, and that's when my colleagues collected all this data. So they surveyed all full-time VA chaplains. That gave a 75% response rate, and all active duty DoD chaplains at the time, there were nearly 3,000 and about 1,700 replied. So that was about a 60% response rate. So that was a large-scale survey. At the site visits to 33 VA and DoD facilities, there were nearly 400 individuals interviewed, about half each of chaplains and mental health providers. And in addition, there was a task group of 38 professionals. So again, that extensive empirical basis for developing mix. And during the JIF era, subsequently, the Joint Incentive Fund supported the first several cohorts of the mix training, specifically travel for our in-person intensives, and the continued work that we did to improve the quality of and track the quality of the training. So the N equals 40 for mix there reflects just the average cohort size. At this point, about 250 chaplains have completed mix. During that JIF era, there was also funded a learning collaborative, which was a venture that included mental health and chaplain teams at VA and DoD hospitals, and other development of other educational materials. So let's continue on with describing the mix training. Next slide, please. So the mix training, based on all that empirical work, aims to equip chaplains to identify signs and symptoms of mental health problems. And although our initial focus and continued focus is on those needs of veterans and service members, as more chaplains in civilian settings, thanks to the DMIN, are participating in that program, the application we're finding is broad to many care contexts and the concerns therein. So one of the key aims of mix is this second bullet. It's to support chaplains in integrating principles and practices from 3 evidence-based psychosocial care modalities that already have a solid research base and resonate with spiritual care. And that's acceptance and commitment therapy, or ACT, problem-solving training or therapy, BST, and motivational interviewing. And these modalities provide both new exercises, new approaches, and a common language for existing spiritual care approaches. All of these interventions aiming to enhance spiritual care for mental health concerns in particular. And the second way in which integration happens in mix is at the systems level in this third bullet, through collaboration with mental health professionals. So we're helping chaplains thinking about bidirectional exchange of referrals and starting with mutual understanding of services offered. So I won't continue with all these aims. It's just to say that all of this is in service of improving care for those in chaplain's care through fostering prevention of more severe mental health concerns, fostering resilience and human flourishing. Next slide, please. And so, as I mentioned before, mix now, in addition to being a standalone training in VA, forms the core of the first 3 semesters of a Doctor of Ministry degree in integrative chaplaincy offered by Vanderbilt Divinity School. And as such, our VA training is in sync with the academic calendar. So mix is 3 semesters starting this fall. A new cohort will be starting this fall, and the applications are due at about April 1st for Vanderbilt. It's a hybrid of in-person training intensives and distance learning, in which chaplains complete assignments asynchronously, and we meet weekly for consultation. I meet chaplain coaches, as Keith mentioned before, and I meet with the participants every other week and facilitate these consultation calls where the expectation is that chaplains are working full-time in some sort of clinical context or an operational context in the case of the military at times. Whatever your distinctive context, you're actively applying the material there, and that's the focus of the consultation. So if you or someone might be interested, feel free to email us or visit our IMH website or the VDS website. So if you're in VA, you're eligible for mix as a standalone. And if you're outside VA, you can reach out to us as well for more information or go straight to the VDS website. And a little more on this in the next slide, please. As of last spring, over 200 VA and military chaplains had completed mix, or that portion of the DMIN. And at that point, 14 in other contexts, such as civilian healthcare settings, also schools, prison facilities. So counting the chaplains currently in the program, there are over 300 chaplains in this network. And we're so grateful that we could partner with VDS so that this content could be accessible to more chaplains. Next slide, please. And just one way in which we've evaluated the program is by whether chaplains do endorse that they're integrating the evidence-based practices over time. So the ups and downs of this line graph, each line represents one of those three modalities, ACT, MI, or PST, or any of the EBPs sort of combined. And the ups and downs of the line graph reflect that actively during the program, we're emphasizing different modalities, so that's expected. But what it does show also is that over time, there's a gradual increase. So we're just looking at two of the cohorts for which we also had data from our post survey, which was about a year and a half after folks had completed mix. And not only had the use of evidence-based practices increased over time, but that had persisted, which is really great to see. And one more slide, please. Since we spoke about moral injury specifically, we have a slide here as well. Moral injury is just one of 50-odd modules in the training program, but it certainly is a very popular topic among the chaplains in their case material, in their papers. So we had the privilege of having experts like Bill Nash and Jonathan Shea speak to moral injury in sort of a historical sense, and we've had the opportunity to bring forward some of the thinking about how chaplaincy and moral injury works together so importantly. So folks are seeing it outside of the war context for sure, and beginning to write about it in their final doctoral projects, which is very exciting. So with that, I will turn it over to Melissa for our next segment.
Sounds good. Thanks, Jen. And Sam, you can go to the next slide. Thank you. So as you all have heard by now, we are a program office within the Veterans Health Administration, which is a healthcare system. And so we are committed to enhancing the healthcare that veterans receive, particularly at the intersections of mental health and spiritual needs. And we've tackled this in many ways over the years, but today I want to focus on activities over the last several years when we've been able to provide leadership to the field in the area of moral injury care. Next slide. So in about 2008, IMH started to intentionally examine what was happening in the field in terms of moral injury care, and we discovered that there were some very interesting things happening. In particular, there were teams of mental health providers and chaplains who had been through the mixed training program, who were working together to develop novel interventions to address moral injury. However, these teams were largely unaware of one another and what the other teams were doing. And we saw this as a problem that could be fixed. And our solution entailed developing a process by which these providers could learn about and from one another. And we called it the Dynamic Diffusion Network, or DDN. Our definition of dynamic diffusion is really wordy, and each word is loaded with meaning, so I want to break it down with you. First, dynamic diffusion is, as you can read there, an innovative approach to intervention development and dissemination. Now, in a healthcare system like the VA, there are lots of well-established models for developing therapeutic interventions and for spreading them across the system. But none of the existing models adequately addressed this particular conundrum presented by moral injury, which is it was a new problem without clear solutions and with veterans who were clearly suffering today, as well as care providers who wanted to respond to those needs today. So in other words, we needed a model that was both responsive and reflective. We needed a model that would allow us to care for the suffering existing today in the absence of clinical best practices or guidelines, but doing so with accountability and fidelity. And so in the DDN model, going back to our definition here, care practices are delivered and continuously evaluated under real-world conditions. So for care practices to be rolled out in a system like the VA, they typically have a wealth of empirical evidence demonstrating the benefits. But the process of generating that evidence takes time, years, sometimes decades. And so the DDN model allowed for more rapid implementation of these novel ideas, but with continuous monitoring and evaluation to help understand and track the impact. Going back to our definition one more time, all of this is happening as part of a structured network experience that promotes cross-pollination of ideas and shared learning to generate relatively rapid improvements in care. That's a mouthful. So in other words, we wanted to make sure that these innovators were learning from each other and adapting as needed in real time. This helped to ensure that these innovators were not developing their ideas in silos, and by sharing their experiences and their lessons learned through this DDN model, we could then convey that learning to the broader field as well. I mentioned the absence currently of clinical practice guidelines or a best practice to address moral injury. And one of the things that makes this DDN model unique is that it is designed to foster a diverse range of care practices that can serve veterans in diverse ways. So the goal is not to pit these different approaches against one another and have one emerge as like the winner, but instead we want to understand the nuances of these different practices, as well as the nuances of individual veterans and different care contexts in order to offer an array of care practices that can meet unique needs. And I'm going to give you some examples of that later on. Next slide. So the shared learning aspect of the DDN is made possible because of the network of care providers who participate. We've had 3 separate DDN cohorts to date, one that focused on suicide prevention and 2 that have focused on moral injury. And as you can see, the network spans from coast to coast, and it includes rural and urban care contexts. And we're really excited to see this network continue to grow in the coming years. Next slide. Importantly, we don't want to limit the lessons learned in the DDN to only providers who are part of the network. And so another offering of integrative mental health is moral injury group facilitation training using 4 of the DDN practices. So these group interventions were developed by frontline VA mental health professionals and chaplains from across the US, from Portland to San Antonio to Memphis to Philadelphia. And in addition to going through the intensive DDN quality improvement process, these groups are subject to ongoing revision and refinement. Each group conceptualizes moral injury in a unique way, and then the intervention components flow out of that conceptualization. For example, the moral engagement group conceptualizes moral injury specifically among combat veterans as resulting from the inequitable distribution of appropriate moral pain. And so to address this inequity, the climax of the therapeutic group is a community healing ceremony in which civilian members of the community bear witness to the veterans' stories and take on a share of the moral pain of war. Another approach, REAL, conceptualizes moral injury as the fracturing of one's meaning-making system as the result of a violation of what's right, which requires identifying and grieving important losses in order to reconstruct a world of meaning. And this is accomplished through grief work and shared lament. Each of these moral injury group approaches could have a webinar unto itself, but you are welcome to reach out to me and I can send you additional information and research articles about any approach that interests you. Next slide. Through working with these intervention developers and consulting with other moral injury practitioners in the field, it became apparent that more education about moral injury is desperately needed, both for providers and for veterans. And so IMH convened a work group to develop an educational curriculum for veterans that could be used as a precursor to any of the co-facilitated therapeutic groups that were on the previous slide. We are currently in the midst of pilot testing this 4-week curriculum and hope to make it available to VA providers in the spring. The group is 4 sessions long, with each session lasting just under an hour. And the curriculum covers topics ranging from morality and what it means to be a moral person, moral emotions, how moral injury manifests, and potential pathways forward. Next slide. IMH has 2 other major offerings to provide education and support to the field, one of which is individualized consultation. So while co-facilitated groups are the only modality in which we provide training, we are able to provide consultation to practitioners using other modalities or who are simply interested in learning more about moral injury. IMH also hosts a monthly moral injury office hours, which is open to any VA provider with an interest in moral injury. And this forum is moderated by our staff and is a space for providers to bring their questions to be addressed in a public format for the benefit of others, as opposed to the individualized consultation, which is private. In both of these settings, we cover topics like moral injury conceptualization, intervention approaches, screening and assessment for moral injury, interdisciplinary collaboration, as well as resources pertaining to all of these topics and more. And consultation often unfolds across several meetings as we help practitioners discern their needs and develop a plan to address them. Next slide. Thinking beyond the field of VA chaplains, IMH does strive to communicate what we're learning to the broader field through research and scholarship. In 2022, the Journal of Healthcare Chaplaincy released a special issue that was guest edited by members of our program staff with articles that focused on moral injury care practices and collaboration. And a selection of intervention-focused titles are listed here, and we'd be happy to provide these resources to folks if they're of interest. So you can email imh@va.gov and let us know which article or articles you'd like to receive if you don't have access to them in another way. Next slide. Also in 2022, we published a paper describing core components of the moral injury groups that were part of the first DDN moral injury cohort. So our process entailed examining 6 different moral injury groups to see what they had in common in terms of both content and process. And while each one conceptualized moral injury in a different way, they all had a clear conceptualization of the problem that was reflected in the intervention components. They all specifically utilized a group modality as opposed to individual care, with the express purpose of combating shame, which is a hallmark of moral injury. Each group also had an inclusive approach to religion and spirituality, and this specifically entailed designing the group to be appropriate for veterans of any religious or spiritual perspective or none, including folks who identify as agnostic, atheist, and humanist, as well as creating spaces for all of those perspectives to coexist and inform the collective group experience. So these are just some of the core components. There were 10 in total, and I'm just going to mention one more in some detail. Each of the moral injury groups addressed the topic of forgiveness and responsibility in some fashion, some to a significant degree and others more in passing. And so we really think that this suggests that it may be necessary to discuss forgiveness in the context of moral injury care, but also that it's a highly individualized and personal process. And we are convinced that the topic of forgiveness should be addressed judiciously, as missteps in this area have the potential to cause harm. So in all of these quality improvement activities related to moral injury, one of the ongoing challenges is the lack of consensus on a definition of moral injury and the associated signs or indicators of it. And so for this reason, we really want all of you and all of the people that we work with to be in the habit of asking, what do you mean when you say moral injury? This invites all of us to be thoughtful about our use of the term and promotes greater transparency as we deepen our understanding of what it means. Last slide, please. So in addition to examining provider perspectives on moral injury, we are soliciting veteran feedback about collaborative moral injury groups through interviews, small group discussions, and clinical outcome data. In his seminal book about moral injury among Vietnam veterans, Achilles in Vietnam, psychiatrist Jonathan Shea says that, quote, what a returning soldier needs most when leaving war is not a mental health professional, but a living community to whom his experience matters. There is usually such a community close at hand, his or her surviving comrades. If both mental health professionals and chaplains made authentic communalization of soldiers' grief their goal, they would do more good than the best individual counseling. So we were very fortunate to have a group of veterans who wanted to share publicly about their experiences in a moral injury group, and you can view the 10-minute video through our website or on YouTube. And Nancy, this concludes the formal presentation, and we look forward to discussion.
Great. Thank you so much. Yes, let's get that. We fill this page, don't we? Well, there's a lot of appreciation on the chat, but folks were closely listening to what you had to say, so I will watch for more of that. But I tried to make some notes myself, so as I wait for more to appear, I'm wondering if you could elaborate on the access of your programming for active duty chaplains in the three forces, and those that are teaching in that program, in their various programs, to incorporate the resources that you have developed. Do those folks have access, knowing that this is a VA program, so separate, do they have access to this?
Jen, you want to have a conversation? It's a quick yes, Nancy, but I think Jen could most appropriately maybe discuss just how we do that. We have a number of DoD students every year, but Jen, you want to address that? You're muted, Jen.
Yeah, that would be good to unmute. Absolutely, there are. I don't have the count offhand, but for instance, every year about 8 Navy chaplains, all of whom are active duty, participate in the program. So the different services have different levels of support for individuals going through the program. Navy has committed resources to support 8 active duty Navy chaplains through every year. So the content is basically housed in the VA, and it is definitely accessible and relevant to folks who are in active duty settings.
Just a comment. I mean, Jen, you might mention that this past intensive, we had DoD from, let's say, Bahrain, Japan. I mean, so they're able to make the intensives as well, Nancy, which we really appreciate the services supporting that. And in the past, we've had folks in Germany, just literally around the world. So
that's right. From around the world, they come in for the intensives and dial in for the consultation calls, sometimes at odd hours of the day, and still make that work. And even in cases where folks sometimes are in transition and have limited access just temporarily to either the internet or to even cases, we work individually with each of them to support their progress through the course. Figure out how to make it work.
Yeah, and I just quickly add, everything I was talking about is freely available on the website. And then Melissa, I know we've had some experience in active duty coming to office hours. Would you want to highlight anything that active duty might find of use versus things that maybe not so much that are more for VA?
Sure. So the DoD chaplains who have shown up in office hours or sought consultation have been folks in the MIX/DMIN program. So that's sort of how they've found their way to us. But, you know, given the nature of the questions that we address and the help that we provide, we really, you know, are equipped to assist them as well as anybody else. We do oftentimes run up against the challenge of the groups that I described being designed for, you know, outpatient healthcare contexts where someone has the opportunity to convene a group and to meet with them, you know, multiple times over many weeks. And obviously that's different in the military context. So, you know, things are not always directly applicable, but their questions are different too. So we just try to meet folks where they are with whatever it is that they need and figure out how to adapt the things that we know to that context.
Mm-hmm. Just to follow through a bit more on this, we've variously had opportunities to talk with, through our webinars, training programs in each of the three services. And I'm also aware that, you know, the training for chaplains when they enter the military is spread out. And often they're relatively brief segments, and then another one will occur. And for some, then there's ACP training a bit later. And part of what I'm wondering about is how actively your center and the VA perhaps makes these different chaplaincy training programs aware of the resources that you have for them to employ in the relatively brief spans of time that they address this over several years with chaplains.
I can say a little about that, Nancy. And the maybe short answer is this has been an ongoing conversation, an area of interest with each of the three branches for over a decade. And we've answered it in kind of a variety of different ways. Chaplains, of course, in the military serve in lots of different operational contexts. The training that, you know, Jen was talking about, our Doctor of Ministry program, prior to offering that DMIN, we had developed the mental health integration for chaplain services, what we call our mixed training program, following on an intensive gap analysis we did in the Department of Defense and in VA, looking at what are the needs of chaplains and of mental health, how can we better, you know, get the disciplines to collaborate. A number of different things came out of that. The mixed training was a primary thing. And the military chaplains who went through early iterations of that talked about how transformative it was. And there are a variety of different ways that, you know, those chaplains and chaplains who go through it now continue to take principles that we train and then, you know, adapt them into train the trainer models or things like that, that they'll take it back to their command. But also one of the things that we've worked through with each of the branches is figuring out, you know, which kind of billet is most appropriate for going through this intensive training, recognizing that not every billet's going to, you know, be able to do that at any given time. And so, you know, each of the branches has had different capacities to think very intentionally about this. Navy's been the one that's thought most intentionally about, you know, trying to figure out, you know, what level chaplain do we want going through this training, who can apply the training, because they've been in Navy for a while, but they're still seeing folks. They're not at, you know, a level necessarily in the Navy where they're, you know, just completely administrative, but they're on their way there and can see ways to use some of these principles, you know, across Navy. So there's lots of different ways that it plays out.
And just a slight addendum to what Jason so thoughtfully said just then was that, and along the way, and we continue to be interested in if there are modified versions of what we do, Nancy, that would be of use to any of the services that we can work with. We've always been engaged in those conversations at times, willing to look at that. Of course, we understand that there's a lot of commitment within each service, each branch, for their own work, work that they've developed, et cetera, which we honor completely. But I think we continue to be, along with the commitments that Jason was just articulating, committed to, if there are modified versions that fit the vision of evidence-based practices built on the fullness of the practices of chaplaincy, we're intrigued with that and very willing to kind of explore that and think about it with any colleagues in the DoD.
Well, that's encouraging. Since we mostly, our programming is focusing with chaplains in the service actively, and chaplaincy education, then I'm aware of how brief that time is, and the challenge of what they fit in. So the fact that you have these media options, for example, for continuing education or additional supplemental to folks early on, it seems to me important thing, that a place for collaboration. But I'm well aware that I do not know the intricacies of cooperation between the VA and the Department of Defense, and so this is part of why I raised this, and also just an awareness of the fact that there are more suicides now on bases than there were earlier. That that this is a problem for active duty context as well as for veterans. Is part of why I'm raising this concern, as well as military.
No,
Go ahead.
And I appreciate it, Nancy, very much. And as we've tried to emphasize from the beginning with our IMHS surveys that we did, et cetera, we've been integrally related to the DoD, and we have had active duty participants in our programs all along. There's always the nuancing, which some of our colleagues on could probably speak much better about, between each of the services have some of their own commitments, which we really honor and appreciate. But I think the commitments, the viability, and the relevance of what we're doing, you're nicely pointing out, I think, fit across the spectrum. Yes,
right.
Relevant in the VA, but across the spectrum. And we really repeatedly, like just even in an intensive we were doing last week, the numbers of times that those of us who were speaking one way or another commented on, and then the constraints of the active duty operational setting, how you might think about these practices in that's standard format for us to be always thinking about operational context and how might this work that we're working on be tweaked to most appropriately serve someone in that setting. So we appreciate your emphasis on that a lot. Thank you, Nancy.
Sure. Well, I probably will raise it again, but I'm mindful of the need for deeper resources, which is not to criticize what they have. It's just the need for these wider resources, or the depth of what you're raising, as accessible, because, of course, one functions as a chaplain immediately, and the training is spread out over a series of years. The complexity of people's lives don't wait until you're in your third year to present themselves to you. And given the precarity that I mentioned in terms of suicide rates now, and the SAPR reports that for even in our academies at the highest rates ever, I guess what I'm trying, without trying to sound too histrionic, there are, pressing issues. The other thing that I wanted to ask you about was the ways in which you are able to reach out to, it's clear that you're interreligious in focus, as of course I would expect. We're aware at the center of the ways in which there are denominational resources, or groups within various Protestant denominations, for example, that seek to make these resources available and stay up to date on them. And I know in our own program that we have a decided interreligious commitment with, imams and or Muslim chaplains and rabbis as well. And so I'm interested in the ways in which you have or might consider alerting these organizations to your resources for their religious leaders.
Maybe,
I'll just, yes, Jen, go. I mean, we're absolutely committed to that, and I'll let you, Jen, go. We've had rabbis and chaplains with Muslim heritage included a number of times through the years, and our last intensive just last week we had one rabbi, and then in the December intensive we had another rabbi. So we're very committed to that. I think, as you know, Nancy, how we reach out to those is sometimes personal. Sometimes, I mean, that's a great encouragement from you. But Jen, you were going to say something.
Yeah, thank you, Keith, for speaking generally, because I wonder if each of us heard the question in a different way, because that's a wonderful point, that although it's a small number of folks outside Christian traditions, we have had a couple Buddhist and several Jewish and a few Muslim chaplains as well in mix through the years, and they have been a wonderful voice, as all the voices are important in the program. What Nancy's question got me thinking about was an interesting blend, a wonderful recent opportunity that sort of addresses both of your questions, which was that and I'll just relay the anecdote very quickly, that it happened to be that a recent Navy chaplain, graduate of mix, and just before she was completing, was in the same denomination, Christian denomination, but a historically Black denomination, and an Army chaplain who had completed mix years ago. They joined forces to provide a brief training to their denomination, and it was very. We were able to support them with a slide deck of condensing some material that would be quickly usable, as well as with some video clips that would be usable in the moment. And it was very important in kind of addressing acute needs with for missionaries who were in Israel and Gaza, as well as to all the pastoral care providers who were in the United States and around the world. So that was a beautiful blend of chaplains with from a military setting reaching out to their denomination.
Yeah, I would just want to emphasize while we're on some of this content, Nancy, as well, which I think you know this about us, but one of the highlights that we feel like that we're very proud of, but also very thankful for, is that, as Jim was just mentioning, along with the diversity with Buddhist, Jewish, Islam, Muslim folks, etc., we have a broad spectrum of across the theological divides of Christian practices. And it's one of the things we take a lot of pride in some ways, that we have very conservative, from more conservative traditions like Southern Baptist, PCA, etc., to Unitarians, UCC, whatever you think of as representations of the arms of the Christian tradition. And one of the things that's very encouraging to us is that we see those folks really embracing one another, living together in a zone that we frequently don't see sometimes in our culture, while examining practices of care. We see regularly that when they come together, thinking together in consultation groups with Jen, and work with their intensive, that when they start to really focus on learning practices of care together, it really helps bridge a lot of that spectrum that can seem so dividing at times, to be honest with you, in our country now, etc. So we're always very encouraged to see chaplains representing those divergent arms, even within the Christian tradition, as well as those that are outside the Christian tradition. And that we see that as a real plus and a real asset of this work that we are able to do with the framework that we've developed through the years.
Oh, I agree with you. That can be very helpful. we're also reaching out here at the center to associations of what would be continuing care retirement communities. So retirement communities, and there's typically one or more chaplains depending on the size at such locations. But part of what I'm aware of is how many Vietnam veterans and older than that veterans are in such places, and the ways in which resources for keeping difficult memories back diminish, so that they may present themselves in a way they had not before later. So the other group I would encourage, I'm wondering about your reaching is the groups of those communities and alerting their chaplains. So it's just, one goes, there's just a plethora of possibilities as you try to think about where are these veterans located. But of course, the veterans in Afghanistan are right here among us. So this is part of why I was lifting this up. I have another question for you then I will look again at the chat. But recently, in fact, our last webinar addressed racism in the military as morally injurious, which I'm deeply regret saying is the first time that many of our participants indicated it had been named in that way. And I'm wondering if your resources give attention to the ways racism in the military is morally injurious and has a long effect on the lives of both active duty and veterans.
Melissa, would you be willing to comment on that? Along with, if I could just add in at the same time, Nancy, LGBTQ concerns and
that's true.
Morally injurious issues, that because we had some rich conversation around that last week. Melissa, would you be willing to comment on that?
Yeah, absolutely. So I mentioned that the different group approaches that are part of our DDN process and whatnot each have a unique conceptualization of moral injury. And this is the kinds of issues that you're speaking to are precisely the reason why I think it's really important to have that kind of conceptualization, because there are approaches out there that target moral injury from a very particular lens that might not be inclusive of those kinds of experiences. And so I think, as we are refining our understanding of, what moral injury is and what can lead to it, I think it's important that we be mindful of how our approaches to care reinforce certain ideas about what it is and what it is not. So I will say that, thinking about the different approaches that we certainly have some that are very deliberately inclusive of whatever a person perceives to be morally injurious. If they identify that there was a violation of what's right and they make the connection to how it has negatively impacted the way they see themselves, other people, the world, it is up to them to say what moral injury, is for them. And so we have had individuals in our groups that I am aware of who have had race-based trauma address those issues in the group.
I appreciate that. I guess part of why I brought up the racism in particular, Keith, was that it had never been addressed as moral injury. And it was very important that we named this, and we discovered that attention to training for officers, even to understand racism as morally injurious, was simply not present. So they're just finding areas like that seem to me just calling for the attention of the kind of creative work that you're doing. And so that is the other area I wonder about is relation to unhoused persons, because a couple of years back, I think maybe at least one, we had a webinar that addressed unhoused persons, and one of the members was a therapist who had previously been associated with VOA, and she indicated a high correlation between unhoused veterans and experiences of moral injury. And so it's these various issues and identifying those. That's part of why I lifted up religious leaders in addition to your contacts within the military links itself, to understand what could be an important aspect of a person's pain or self-isolating behaviors that they bring from military experience. One might have no idea that they were in the military before. But I know, Jason, in some of your work that you've presented on our webinar, that there's a long shelf life to moral injury for veterans.
Yeah, and I was just not to circle back to your prior question. Melissa, I want to have you talk about any of your thoughts about San Diego, but I was just looking up our paper that we published in Journal of General Internal Medicine a year ago. We were looking at moral injury in post 9/11 veterans and comparing it to healthcare workers, and we looked at sort of. I know there are a variety of different ways that this is named, and you remind me again what your preferred one is, Nancy, but sort of the self-induced versus other-induced, or transgression versus betrayal, kind of that notion. So we were looking at both those in veterans and in healthcare workers, and then we looked at a number of these different demographic variables to see, was there variation depending on age, gender, race, and that we looked at also other things in veterans like number of deployments and whatnot. But we did see among veterans that gender and race both were predictive of higher levels of this other induced, this notion of betrayal based moral injury among veterans. So specifically identified as either Black or female. And so, exactly what to make of that. But certainly, you can kind of think about the importance of power and authority. You can think about Jonathan Chea's definition, right? The notion of someone in authority and who has authority, who doesn't have authority in different cultures, and how that then influences, risk for moral injury. Now, the reason I mentioned San Diego, and Melissa, I don't know if you want to speak to this at all, but there's a residential treatment facility there for veterans with comorbid homelessness and PTSD, and they've recently started offering moral injury groups. And many of the veterans who have gone to that center, they're there for 6 months. It's very intensive. And when we've interviewed some of them, it was the moral injury group that was fairly new, and they just started offering. They said, of all the things offered here, that's the thing that seems to be getting to the heart of like all of my challenges. But
I see a couple of the questions that Jason and Melissa, you can both be thinking around impact of DDN and any data or evidence around that. While I know that's an area we're continuing to work on, I think we've got some information that they may be able to share, but it's a high priority place to us of VA database with regard to the electronic healthcare record, of being able to capture that in more detail and more fluidly. But I will tell you one of my favorite anecdotes of our work that when we were doing some interviews about the groups that were part of DDN, and it's an important notion embedded within this that I'm about to say is, I think, crucial within talking about data of the impact of DDN on a veteran, is what's our dependent variable? What are we thinking? How do we really measure? How do we really assess the important parts when we're realizing that some of the challenges in mental health don't go away? Some of the symptoms don't all disappear, et cetera. But one gentleman that we interviewed that had been in a group, one of the collaborative care groups, he had a burly guy, a post 9/11 young man with all the physical trappings you might expect for someone that had been through all he had been through. And he was talking quite transparently and candidly about, well, you know, I still have some anxiety, and I am still depressed at times. He's talking about things that we might standardly measure by some standard modalities. But he said, but you know, I can love again. That captured my imagination. It was powerful, this young man saying, I still struggle with X and Y, but I can love again. And commenting about his wife, noting that he was able to embrace the family and care in a way that he could not do before that group. I think that speaks to an importance of what we think of as the dependent variables that we're measuring when we do think about this. Do you guys have any comments on the DDN groups or feedback that you've gotten?
Please clarify DDN.
Oh, I'm sorry. That Melissa talked about, Dynamic Diffusion Network.
Right.
And then a couple of questions from Rita and Kyle. I was just, if we can.
Sure, it was just, right.
Yeah, I want to piggyback on that, Keith, and use that example of this veteran who's able to love again to tie together a couple of the other threads of what Nancy and Jason were saying just before that. Thinking about persons who are experiencing homelessness, and that can often be comorbid with, you know, substance use issues, as well as people who, you know, identify as LGBTQ, things of that nature. And so it's interesting to think about, how does moral injury factor into that picture for some people? And if we understand moral injury to fundamentally impact the way a person sees themselves as well as other people in the world, a big piece of that for many people is viewing themselves as fundamentally unworthy of love and belonging. And what that can lead to is isolation, is, you know, addressing that heart issue in ways that we would consider to be maladaptive or destructive. But it can also lead to people engaging in behaviors that they might not otherwise do. So, for example, we had some conversations last week about you know, individuals who are ostracized by their faith communities and their families because of their sexual identity, and they are internalizing that there is something wrong with them, and so they, you know, go out and, you know, try to engage in relationships that would be acceptable to these communities that they're a part of, and in so doing harm people who they're engaging in those relationships with, because they're not being authentic and the feelings that they're expressing are not genuine, and so the person on the other end gets hurt, and then the person is left not only suffering with feeling like their own identity is flawed and that they're unworthy of love and belonging, but now they've perpetrated harm on some innocent person who got wrapped up in the whole mess. And so I think that's one of the ways that moral injury can actually show up in a agential form. Same thing happens when people talk about their experiences with substances and the things that they do, you know, in order to procure those substances, or when they're under the influence of those substances, and it just feels like a different person and they don't know how to reconcile those things. And so I think that, you know, can be understood as moral injury. And so to Keith's point, how do we then measure, you know, the impact when we've got such diverse manifestations of the struggle and of the recovery, you know, from it? That being said, and I'll take a stab at this, and then Jason, if you want to add anything too, we are attempting to answer that question both on an individual intervention level as well as in the aggregate. And so the approaches that I had up on the screen before, 3 of the 4 of them have published articles that present preliminary empirical support for those approaches that show moves in the directions that we want to see in terms of PTSD symptomatology, depression symptomatology, suicidality in particular, religious and spiritual struggle. We've also seen increases in things we want to see, like psychological flexibility, you know, forgiveness, things like that. Those are small numbers of folks, and they're not controlled studies. And so, you know, there are all kinds of critiques that could be made, but there are certainly signals that we find promising. And that's part of why we do want to look at this in the aggregate. And so part of the current DDN, Dynamic Diffusion Network, work that we're doing is with the teams that are providing these groups in VA. We have them systematically collecting pre and post data using a depression measure, a PTSD measure, a measure of well-being, and a relatively new on the scene moral injury measure. And yet, even with those, we're beginning to be able to look at some of the preliminary evidence. And when you look at the actual items, the questions that we're asking, particularly when it pertains to the moral injury measure, they're not necessarily things that are going to change. So for example, Jason, what's the one you always use from the MIOS, the item? I'm blanking on it right now.
Oh, I blame myself.
Yeah, thank you. I blame myself is one of the measures on the moral injury scale. And, frankly, our goal, to get back to that point, with these moral injury interventions is not necessarily to shift the blame somewhere else. So a person, may not change on that item, and that's not necessarily a good thing or a bad thing, right? So it really matters how we are seeking to evaluate the impact. And the anecdotes like the one that Keith shared, and if folks have the opportunity to watch the video that will be linked in on the final slide of our presentation, hearing from veterans about the impact that the group has had on their self-perception, on their relationships, on their ability to experience meaning and purpose in their lives. We don't have a measure for it that boils it down, nicely and succinctly, but boy, the stories speak for themselves.
Mm-hmm. Mm-hmm. One of the things that I had imagined you might mention, and perhaps I missed it as I was taking notes. I recall when you first introduced me to your work that there were a number of really effective videos that you had prepared that religious leaders could use, for example. And I'm assuming you still have those. And I don't know how do you make various organizations, including religious organizations, aware of those resources?
Jason.
Yeah, so some of the first couple slides I presented are those videos, so folks can get access to those. And to your point earlier, Nancy, if you have thoughts about, here's how we could get into different denominations and organizations, that's excellent, and we are all ears that way. Our approach over the years has been, whether it be with those kinds of resources for communities or with training that we're doing for chaplains and healthcare organizations or the military, it's often been going through chaplains that we're working with in training, who we make them very aware of, here's these resources or those resources, and then they'll go to their denomination or whatever it may be, their community, and then, hey, let's feature these things. And that's been part of our spirit, even just in training chaplains as well, in VA. So we have some ability and we'll do some work saying broadly to the VA system, hey, it's important to think about chaplains when you think about mental health care, and you should integrate care services. Like, we do some of that, but a lot of the way that we operate is really empowering chaplains to do that work, in large part because what we always say in VA, you've seen one VA, you've seen one VA. Some VA may have 15 chaplains, another VA has one chaplain. That chaplain may be inpatient, maybe outpatient, maybe in the community living center, maybe. And so there's not a one size solution fits all. So we've often really tried to empower chaplains with the ability to go back to their local facilities and say, here's what I can offer, and here's how we might integrate. And so in a similar way, I think we've tried to approach some of our community engagement work that way, of empowering folks who go, hey, this makes sense, to then go up through their chain or their leadership or their community and say, let's put these out there. But we're also open to, hey, if you've got a way to plug this some other way, that's great too.
I do hope we can make sure that our website is readily available to all on the webinar, Nancy, because those materials you were alluding to, as Jason just stated, many of them he noted in his presentation, and we do want to make sure that folks know how to get there and know that those are easily accessed, and they're there, and we want them to be there for their benefits. It is amazing how the the example Jason was just alluding to of how many times chaplains we've known for years, when they, they'll start working with us, and they'll be learning about some of these things. And 2 to 3 years later, they're telling us we now have 12 chaplains at our VA because people started learning in the mental health and other services about what they could do now. And there's a very compelling story of increasing the number of chaplains, which is always very heartening to us when we hear that story, and that it made a difference in their ability to really have more doors open for them by leadership in the facility.
I'm sure that strategy works. I think it might also be useful, and I'll be glad to share some of the, I don't just mean Christian denominations. I also mean other religious traditions, and then groups that I also mentioned that you can also think about police and moral injury, for example. But I think it makes sense, to make the larger groups of aware, so it's not quite hit or miss, however strategic and effective that is, for this information to get out. That's part of what I was thinking, and I. Even though
Nancy, we really appreciate you as a champion, because I mean you, and again, I know you're coming out of Brite. I know Kyle's based at Brite, so not to put divinity schools and schools of theology in competition here, but we appreciate any time that you are willing to bear witness, because you've always been a real supporter for us at Vanderbilt. And I do think what you're just then pointing out, I do think that Vanderbilt embodies an opportunity with the D-men for some of that diversity you're alluding to.
Well, it does, but I guess I'm just saying that there are other ways to share this, and I know that Rita hasn't spoken yet about a program that, and I think it was last January. Rita, you're welcome to unmute and jump in on this, but she presented on resilient strength training, which has proven to be a very, very effective program. I'll let her, I know she wants to speak for herself on this.
Yeah, sure. We have a program that we, actually Keith and Jason and I met because of BMS, because BMS was funding veterans programs, and Keith and Jason and I were the only ones that they had funded that were working on moral injury. They had lots of veterans programs they were funding, but we wound up being the only three working on moral injury. So we were in that process with Jason and Keith, and we used the peer specialist approach, and then did before, after, and 6 month later surveys with the participants in the program. I think the hardest part of that is the one that's the longitudinal one, and we, as somebody said, most of those are 2 months out. We made the mistake of making it 6 months out, which chasing down people and getting them to take it was really difficult. And we also had the problem of the survey was long and laborious. It measured, it had these measurements for the same thing from 2 surveys, so that the results could be more solid and all that. And so we actually had a number of veterans come to us that we had been in touch with, or came to a reunion. We had reunion events, and they said, "Oh, I couldn't fill out that 6 month survey. It was so hard to take it the first 2 times, but I want you to know I'm doing great." And that was from a couple of our facilitators we had trained who didn't take the survey. But we had enough to make it legitimate. It was like 37% rate or something. Anyway, but it was relatively successful. I was surprised not by the fact that no one went back down to baseline, but that in several markers, they kept improving 6 months later, that like propensity to trust and optimism. So I do think that addressing moral injury makes a huge difference. And we'd be happy actually to make available the videos that you're saying that are available for these programs. through our newsletter, and we can put them also up at our resources site. We also run the certificate program. We've had 66 people take it last year. And those are all people who would appreciate that kind of set of resources. I think we had this last fall, we had 40 participants, and 17 of them were military chaplains.
That's great.
And
Oh,
one
that-
of
No,
them was a
that's
DDN
shocking.
person. I
What
know
was that?
One of them was one of our DDN people. So that's
Okay.
what they told us they were doing.
Yeah, well, it was interesting because it changed the culture of the group, actually, to have that many military folks in it.
Sure.
But we had 6 from an Air Force base in Japan, and I think another 3 or 4 in the US, and then another team of 5 from Texas. I don't know. It was interesting to have so many military folks. I think there's so much overlap and resonance between our 2 programs that it's really great. I'm just glad there's a place people can do doctorates in this.
Yeah. I think there's actually overlap among our 3 year
Yeah.
2 educational programs and our resources and offerings. So I'm look forward to ways we can help